You're not going to snap your fingers and then I'm all of a sudden wearing a tank top or anything like that.
In the video, I will do that. You'll just be like a jacked guy all of a sudden, and you have like dog ears too. Like, what are you doing?
World of Pain MD podcast is for information, education, and entertainment purposes only. This applies to all information, graphics, videos, and content on the affiliated website and podcasts. The aforementioned does not constitute medical advice, nor does it establish any patient-physician relationship. The information and content on this website do not substitute for any professional medical diagnoses, treatment, or advice. Seek advice from a qualified healthcare practitioner for any questions you have concerning a medical issue, including treatment. Do not delay consultation with a professional or disregard their advice based on the information in this website. The opinions, statements, and views are that of my own and do not reflect those of my affiliated institutions, policy, or any entity.
Hello and welcome to World of Pain MD podcast, where we discuss all things pain with the experts. I'm Dr. Derick Davis, a physician specializing in pain management. In this episode, we'll speak with Dr. Yong about spinal cord stimulation, otherwise known as neuromodulation. Dr. Yong is the Chief of Pain Medicine and Medical Director of the Pain Management Center at Brigham and Women's Hospital. He earned his MD and MBA from Baylor College of Medicine and Rice University and completed his residency in anesthesiology at the Brigham. Dr. Yong served as chief resident and has received multiple awards, including the FAER Practice Management Scholar. Following his fellowship in pain medicine at the Brigham, he served as faculty at Johns Hopkins Hospital as an assistant professor in anesthesiology and critical care. While at Harvard and Johns Hopkins, he has published on opioid management, regenerative medicine, cancer pain, neuromodulation, and practice efficiency. Most importantly, I think Dr. Yong is essentially the James Bond of pain medicine. He takes his neuromodulation shaken, not stirred. I don't know what that was. He's just that cool. Neuromodulation is an innovative supplemental or primary modality for patients who have not found relief through conventional treatments. One of the well-established forms of neuromodulation is spinal cord stimulation, a therapy that uses electrical impulses to essentially block pain signals before they reach the brain. By targeting the spinal cord, neuromodulation can provide relief for conditions such as post-laminectomy and complex regional pain syndromes, as well as certain types of neuropathic pain. In this episode, we discuss some of the real-world applications and realities of spinal cord stimulation. As always, thank you so much for watching or listening. I hope you enjoy this episode and learn something. First of all, Jason, thank you so much for being here, for taking time. I really appreciate it.
It's my pleasure.
First of all, I just wanted to ask, so what got you started or involved or interested in pain to begin with?
I originally thought I was doing pediatric anesthesia, and then I did the pain rotation, and I thought, this is amazing. You get the ability to have longitudinal care and seeing how patients respond and get better, more functional. You do different interventions and think outside the box because it's still an emerging field and we're still trying to blaze that path forward for what healthcare is going to look like in pain medicine. And the ability to be able to play a small part of that was very exciting to me.
When did you do your first pain rotation?
Pain rotation?
Like, were you like
I was a resident.
Okay,
I was a resident. I was back 2008, 9.
Yeah.
Yeah.
And you also have your MBA, and you got your MBA while getting your MD, is that right?
I did. I did the joint MD MBA program at Rice and Baylor.
Okay.
So it added an extra year, but was a 1.5 year long program. So one of the summer internships we did counted as the other half of a year. So instead of 6 years, they condensed it down to 5 years.
And I know a lot of people often have questions about your MBA, and I feel like we could have a separate conversation, a whole podcast on that. But so I will save that, and maybe we can talk about it in the future. But let's get into the topic today, which is spinal cord stimulation, neuromodulation. First of all, what is spinal cord stimulation? What is neuromodulation, and how does it treat chronic pain?
Yeah. $1,000 question. I think it's still emerging in terms of the theory of how it works. Mm-hmm. But the concept of it is neuromodulation is creating electrical signals around the spinal cord or sometimes in the brain for DBS or deep brain stimulation, but trying to create an electrical field around the spinal nerves to be able to decrease the pain signaling going out to the brain. And so if we can quiet down the pain signaling, we can decrease pain, but then also improve function and hopefully quality of life.
Okay. What conditions do we typically use spinal cord stimulator for?
So the most common ones, post-laminectomy syndrome, or people who have had back surgery and have continued to have pain, The surgery might be very successful in fusing the patient or decompressing the patient, but if the pain persists beyond that, then neuromodulation is a good indication for that. Chronic regional pain syndrome and pain of the extremities. So it can be diabetic neuropathy, it can be chemo-induced neuropathies, peripheral vascular disease, angina. They do a lot in Europe for heart conditions. And the indications are just continuing to expand. And that's the exciting part of neuromodulation.
What about for people who have not had back surgery, but still have back pain or radicular pain, pain going down the legs or just localized to the back? Where are we with that neuromodulation?
So we're still doing studies on patients who have not had back surgery. And the patients who've not had back surgery but have pain that is refractory to interventions, to physical therapy, to injections. Again, these are patients that have failed the first few lines of treatment. And if they continue to have pain, then sometimes we can trial them with a stimulator and see if they can avoid having surgery, especially if there's not a clear surgical target. For patients with clear surgical targets, there's instability, there's movement. Those are the patients we push to have surgery. Or if there are any red flags, we push them to have surgery. But for the ones where there's not quite a defined target surgically, we think that maybe that we can try neuromodulation to see if we can reduce the need for having surgery.
Have you ever used spinal cord stimulator or stimulation for post-herpetic pain?
Yeah, so spinal cord stimulation is great for nerve-related pain. So the chronic regional pain syndrome or nerve pain down the legs, diabetic neuropathy, post-herpetic neuralgia, or people who've had a herpes infection and have continued pain in that specific dermatome or the distribution of their rash are great candidates for that. Where you target's a little bit different. You might have to go a little bit more lateral into the gutter to get the dermatome, but you can also go centrally just a little bit higher up.
How long after they have, an outbreak of symptoms would you wait for spinal cord stimulation? Like they failed gabapentin, they failed medications, they failed topical medications as well. How long would you wait until you tried spinal cord stim?
So typically 6 months at least of conservative therapy before you would make the move. And that's if you've been very aggressive up front.
Okay.
But we really try to exhaust everything we can before we move to something invasive like a spinal cord stimulator.
Got it. And contraindications to spinal cord stim. What are the ones that come readily to mind, and what are some that, looking back, wouldn't be so obvious for us, I suppose?
Yeah. So the infections, the severe stenotic patients where it's going to be very difficult, or people who've had surgery throughout and it's going to be hard to get a lead up into that area. Those are clear ones. The ones that are more subtle, I would say, are the patients with unrealistic expectations. So they come in thinking this is going to be an end-all be-all and they're going to have no pain afterwards. Those are the patients where it's very challenging because you can't quite achieve that necessarily. Some patients, they do great. But if you're expecting that, then those are the patients that are going to be disappointed with 50% relief. And with spinal cord stimulation, we're looking for patients to have that reduction in pain. 50% reduction is success in our book. And so if we have a reduction of 50%, we say that's positive, and that hopefully the patient has better quality of life, better functionality. If they don't, then we have to do some tweaking. But the goal of what we consider success is that 50%. So if a patient has very unrealistic expectations, or they have a high degree of affective amplification of their pain, then they also will likely not benefit long-term from that.
That's really good to know. Good for people like myself that are entering into practice soon. I think it's hard because we don't really know what that looks like. We've seen some of it in fellowship, but I think you just need a lot of experience to really understand when you get a patient that's a really good candidate for that. And in that same sort of vein, are there particular patients or particular demographics or particular set of symptoms that you've seen that just you feel like it knocks out of the park every time, or is it just the case by case?
It's case by case, but the patients that do better on average are the ones with a single area of pain. They're younger, they've had it less amount of time, those are the patients where, all right, I'm going to make a pretty dramatic impact on this patient's life. Patients that have had it for decades, they've almost been habituated to have pain, and it's challenging to reset that habituation.
I find that such a challenging dynamic, but it's so true because the people that have had the pain the longest are the hardest to treat in some ways. And I wish that it was not necessarily reversed, but if we had better sort of ways of treating the individuals that have had the chronic pain for years and years and years, you know, you almost expect then to treatment to take years and years and years sometimes too. I don't know if that's kind of how you have that in your mind as well.
We try to stand by that multimodal interdisciplinary approach where we just throw everything at those patients that have had pain for so long. And part of that is some of the cognitive behavioral therapies and readjusting the psyche and the coping skills and the mechanisms they have to deal with the pain. But then you're also throwing the physical therapy at them, the different types of medications, interventions. Spinal cord stimulation can be a useful tool in that toolbox to be able to throw at the patient. And if you have the right patient, I've seen patients that have been dealing with it for decades do extremely well.
How long after spinal cord stimulator implantation does it take to notice a reduction in pain?
That varies also.
Congrats.
So you have some patients where immediately they feel so much better and they're so thankful. And they might need some tweaks here and there when you need to make an adjustment. If the lead moves a little bit, that those readjustments can be very quick and you can get them in pretty timely. There are some patients where after you've done the implant, you're going very slowly through the algorithm and the different programs that you can take them through. And those patients can take multiple reprogramming sessions before you get them relief. So I've had patients out to 6 months even where you find the right setting at that point. You're like, okay. And they're set it and forget it. And so there are patients where it takes a little bit longer. So I try to set that bar low and tell them it's going to take a few months for us to find that effect.
I feel like that's such a big part of it, that expectation setting. Even before, we'll talk about this in just, a little bit, but like doing the trial or anything like that, how do you set expectations for patients?
Yeah, I try to set the bar low in general. In life, this is... and
every time I get up out of bed, I'm like, no, today's not going to be the day. But
I got out of bed. This is awesome. Yeah, you set the bar low. You under promise, over deliver. Then I think life is easier.
Yeah.
And so I do that same thing with the patients. I tell them, hey, we're looking to reduce your pain by 50%. This can take a while for us to achieve that. But if we can, then would you be happy walking around the mall an extra lap or going to the mailbox, standing up to do the dishes, whatever that objective physical task that they wanted to do, and we can identify what that is and have them be able to do that, then we have some kind of grounding. Because if you just do pain scores, it can shift, mood can affect what the pain score is. Even the same amount of pain can be perceived differently. It's difficult to kind of ground the patient in a level setting that you're trying to do. So I set the bar low when I tell patients, like, we are looking to try to reduce your pain. We want to give it time to be able to do that. And then it's the hard work after that. It's the physical therapy. It's the reconditioning. You've been deconditioned for years. We're reconditioning you now that you have improvement in your pain.
Are there certain side effects, risks, complications you make patients aware of? And then more broadly, I guess, what are the side effects, risks, complications for spinal cord stim?
Yeah, good question. So bleeding, infection, nerve damage are with any procedure that we do. With this, need for further surgery is about 5%.
Okay.
And so I tell them if the lead migrates, if the lead gets disconnected or fractures, the wound gets infected, opens up. When you add them all up, it's about 5%.
Okay.
Then the other one is pocket pain. So there's about a 14% chance for pocket pain that persists beyond the normal healing. And that's for all comers. Old, young, men, women, fat, skinny, like there are, all comers are going to have that type of pain, 14%. The majority of them can get by with it, but there are some patients where you then have to revise it to move it to a different area. or sometimes even take it out entirely.
How do you determine the correct settings once it is implanted for the individual?
Yeah. So after implantation, we typically will start low and go slow.
Mm-hmm.
So with the trial where you are test driving it, putting it in for 7 days, you're running through that shotgun of programs to try to find a signal to see if the patient's a responder or not. With the implant, it's very different. You're sore for a few weeks. So that surgical pain that you have is going to cloud all of the pain that you're having chronically. And so to potentially skip through the programs at that point would be, a big bummer because you're trying to find the right settings. And so what we do is we go very slow and changing the programs in the beginning. At the 3-week mark, 4-week mark, once they come back in, the incisions have healed and we think the leads are more or less stable, then we can more aggressively go through the programs and look for what settings and parameters the patient finds the best.
When someone just gets implanted, day one, right as it's implanted, I've noticed that the reps for whatever company it is, they'll turn it on just very sometimes they won't turn it on, and then sometimes they'll turn it on just ever so slightly. Do you have any say in that ever about how you'd like it to, or I suppose, do you like to have any say in what you want it turned on immediately after implantation?
Yeah, and so what I tell them is to do that. Start low.
Okay, all right.
Almost homeopathic doses.
Okay.
Especially if it's a rechargeable unit, because I don't want them necessarily mucking around over the generator to do the recharging every day.
That's right.
And so that's why I would like them ideally to have a week where they don't have to charge it at all. So the primary cells, that's easy because they're not rechargeable anyway. But the rechargeable ones, we want to start very low so that they don't have to necessarily recharge it before that 1 week post-op visit.
Okay. So a patient says, this sounds good to me. I want to try this out. What's next for you and for the patient?
Yeah. So we set the patient up for a psychological evaluation.
Yeah.
So that we can, it's an insurance requirement, but then also just to make sure they have realistic expectations. After the psychological evaluation, we will do an MRSA swab just to look for a certain bacteria that they might have that could increase the risk of an infection. Then we'll set them up for a date for a trial. During that trial period, they are not showering for a week.
Okay.
And they're trying to function and walk around as much as they can to see if they notice a delta between the trial and before the trial. At the 1 week mark, we pull it out, whether it worked or not. And sometimes that 1 week afterwards is when they really feel like, oh, actually, I didn't realize how good I had it when this trial was in. And so we give them about a week or two and then have them come back in, and then we make the decision together whether or not we're going to go forward with implant. There are some patients that early on, right during the trial, they're like, this is a home run. I want this in now.
Wow.
That's fine. Yeah, I still want them to just make sure that they're ready for this.
So you can decide both at the very end of the trial and then sometimes maybe a week later. Do some people ever take a little bit longer than that, like a month later after the trial? Not really.
Not really.
Yeah.
Some.
Yeah.
But not often.
Yeah. Okay. And then does a trial necessarily need to be 5 days, 7 days? How long is typical trial? I think you said, but is it ever longer than that?
So we can extend it. In certain areas, they'll actually do different types of trials where they'll do a semi-permanent trial. They'll bury the leads and they'll tunnel them off and then have the patient go through a full 1 month trial. And the reason why they tunnel is to decrease that risk of infection going in. Because of that risk of infection, when you just do a regular percutaneous trial through the skin, you don't necessarily want it to be more than 10 days.
Okay.
And so just logistically, because that's how our clinic is set up, we do have about a 7-day trial.
Got it.
We'll do it on the day that we have clinic, and then we'll see them a week after and have them pull it out. There are patients that sometimes needed a little bit of extra time, so they'll say, okay, well, let's extend it to 10 days, see how you do with that, and then we'll pull it at that point.
How would you describe to a patient, and then how would you describe to a fellow who has never done an implantation, generally how an implantation is done?
Okay, so two different answers.
Yeah, two wildly different answers. I know, but
it's all right.
Yeah.
And so these are sterile surgical procedures that are done in an operating room with all the same sterility that you have for any other surgeries, because you are making incisions. You're making an incision in the back that's about 1.5 about 2 to 3 centimeters, and then a 4 centimeter pocket for the generator itself in the buttock. So with those two incisions, we're in the first incision in the back, we're putting in the leads, and then we're anchoring them in so that they don't move as much. Then we tunnel those over to that pocket where we put the leads into the generator and bury that underneath the snake. Everything's closed up and sterile. And about a week later, we take the dressings down and make sure that they're good to go, and then they can start showering again. So when I'm talking to a fellow, what we tell them is, all right, this is a surgical procedure. So a lot of us are anesthesia trained, physiatry trained, neurology trained, psychiatry trained, emergency medicine trained.
All over there.
And so none of those are necessarily surgical subspecialties. Yeah. So a lot of the surgical tenets and trainings we're having to teach the fellow.
Right.
And so when we go through an implant for a spinal cord stimulator, we have the patient prone. We will mark off with X-ray our typically L1, L2, L3 spinous processes. We'll make our incision between L2 and L3, get down to the prevertebral fascia, dissect out, make a bed of fascia that we can bury our leads into and anchor them. We'll get the leads in, anchor them in after testing, and then we'll tunnel over to the pocket that we create.
Excellent. And speaking of that pocket, just like you had mentioned, I think you said 14% pocket pain. What if someone develops discomfort or feels like it's not working for them in a few months? What happens then?
So in a few months, I would still give them some of the topical medications and counseling and time. So sometimes it takes a little bit longer for people to heal.
Yeah.
And if they don't feel like the stimulator's working, give them new programs. Yeah. And just give them the expectation that we're going to have to go through multiple sets of programs before we find the one that gives you good relief. For the pocket pain, if the pain is because the generator is just poorly positioned and is over their belt or under their belt, or in a place where when they sick that it's constantly hitting and moving, might as well bite the bullet at that point and just move the generator.
Okay.
And that can be a very minor surgery. You just need one incision and then move the pocket.
Okay.
And close off the other pocket.
How long can someone expect to have a stimulator in until they will need a replacement?
So it depends. If it's a primary cell and non-rechargeable, we say 5 years, but it can be 3 to 7 years on that.
3 to 7 years.
For a rechargeable battery, those are supposed to last longer.
Okay.
And so that one's typically 7 to 10 years.
Okay.
Depending on how much of the fade that the battery has had. And typically with these, like on your phone, the fade is pretty dramatic. But the fade for these spinal cord stimulator batteries are actually pretty good, where at 10 years, they're almost 90% of where their original capacity was.
Dang. How often would you have to recharge? Do you tell patients? And I know it kind of
It depends on their settings. Yeah. So if the patient is on very low settings, then they can recharge once a week or once a month, depending on the settings and the company too. Some companies have very intermittent pulse dosing where the battery discharge is very low and they can recharge every 3 months. There are batteries that you're constantly recharging, and you tell the patient, just like you charge your phone every day, you're going to charge this every day. And so it's not more often than 1 day, but can be out to 3 months.
What does recharging look like necessarily?
Yeah, so get that question a lot from the patients because it is unclear how they're recharging something that's inside them. But it's almost like the wireless charging for your phones and your headphones.
Yeah.
You have an induction charger that goes through the skin to be able to do that. So that charger is first plugged into the wall so that is charged. Then they can unplug that and put it on a belt and walk around with that. And so while that's recharging, they're able to watch TV, eat breakfast, cook a meal. cooking, if it's dynamic, it'll be harder, but they want to keep it in a stable position.
Okay. And then, so 2 questions then. After implantation, how long until someone can get back to a more active lifestyle?
Mm-hmm.
And then after that, do you recommend or, what do you tell patients about getting back to an active lifestyle? Say some people like to ski or some people like to, play basketball. What do you tell them about returning to an active lifestyle, including exercise and sports?
Yeah. So we'll see them 1 week after,
Mm-hmm.
and I'll tell them you're going to be very sore.
Mm-hmm.
We'll see a month after, and you're just starting to like me at that point again.
Mm-hmm.
And then I see them in 3 months.
Mm-hmm.
And so the progression for how to liberalize their activity, really after 2 weeks, I'm okay with them starting to liberalize their activity and doing well.
Like bending, lifting, twisting sort of thing.
But if they're very active or very young, I want to tell them to be a little bit more conservative.
Mm-hmm.
Don't do anything vigorous for 6 weeks.
Okay.
Really at that 12-week mark, when I see them 3 months after the implant, they can fully liberalize activity. So people have gone back to golfing, kite surfing, whatever it is that gives them that passion. If they're able to do that, then that's a success, because then the stimulator is working. And so we encourage them to get to be more functional and do all the activities that they normally do.
And you can do things like be involved in sports and everything after you've done the stimulator, after you place the stimulator.
Absolutely.
Okay. And then for patients that you find to be interested but hesitant about placement of a spinal cord stimulator or doing a trial, what is your conversation like?
Yeah, so I don't push it.
Yeah.
I tell them this is an option.
Right.
It doesn't necessarily mean that we have to do it now. And so if you need more time to think about it, you want to do more of the conservative therapies, redo some of the things that we've tried, then we should do that. We want to make sure that you have exhausted all conservative therapies before we do the stimulator.
Mm-hmm.
And if they're still resistant at that point, totally fine too.
Mm-hmm.
We will try other things or do follow-ups. And when more innovations come out, we can think if that is applicable to you or not. And maybe at some point you will decide that this is worth it now. And so I try to tell them that this is a decision that we have to make together. Do I think you're appropriate for this? And do you feel like you're ready for this?
Right.
And if those match, then it's time for that. But if it doesn't, then it will lead to failure.
Yeah. The idea of placing something underneath the skin that's implanted to you, I find is very, can initially be in the first conversation, a little bit of a shock to someone. And rightly so. I mean, it's a bit of a radical idea. But what I found is for individuals who've already had back surgery, then it's not that radical of an idea, because they've already had, a large part of what was initially part of them removed to help with sometimes pain. And if that pain persists, or if it comes back, or if it gets worse, they're more open to the idea. Has that been kind of what you found? Just because I know kind of what we do in this regard is a very unique thing. And so, and it can be a radical thing when you first talk about it with someone.
Yeah, absolutely. I feel like the patients that have had multiple surgeries especially are just ready for this. They want anything.
Yeah, a lot of
their pain.
Yeah, they want relief.
Right. And so also patients have family members with pacemakers or with insulin pumps.
Yeah.
Other medical devices that have been helpful and life-altering.
Yeah.
And they're ready for it. And the patients that are not ready for it, totally fine. We might even connect them with an ambassador, some patient who in the past has had the stimulator, and have them talk to the patient on like, these are the things I didn't expect that were good, and also things that I didn't expect that were bad. These are some of the things that I expected were good and expected that were bad. And just give them the real world sense of what it's like to have a stimulator on a daily basis. Because I can't give that to them. I can tell them what other patients tell me, but I haven't lived with it myself.
Absolutely. 2 more questions. Don't want to take any more time, Jason.
Of course.
One question is, any advances that you've seen in the neuromodulation space that you're really excited about?
Oh, so many. So many. I feel like the amount of investment that biotech has had in neuromodulation just continues to grow.
Yeah.
And so expanding indications is the biggest thing. Funding studies to be able to get FDA approval to expand indications for neuromodulation is the biggest way to grow the whole pie bigger.
Mm-hmm.
And we're seeing that.
Mm-hmm.
I think that for decades, we've been innovating on the hardware. Recently, we've been innovating on the software.
Mm-hmm.
And now we're restarting to innovate on the hardware.
Mm-hmm.
Closed loop,
Mm-hmm.
with miniaturization, with the MRI compatibility across the board. These are things that we're looking to do. Remote therapy monitoring, being able to monitor a patient remotely like they do with cardiac rhythm management,
Mm-hmm.
pacemakers.
Mm-hmm.
Being able to reprogram a patient where they don't have to come into the office to do that.
Mm-hmm.
These are things that are going to be cutting edge for every new device coming out, that they're able to do closed loop if they need it and be able to remote therapy monitor
Mm-hmm.
program.
Mm-hmm.
The miniaturization is such that we may not even need big generators and have tiny generators and a small external generator. We have in the head and neck space a lot of innovation that's coming out for headaches.
Okay.
And so the indications, the advancements in the areas that we're going to be able to do neuromodulation in are expanding, and that's what's exciting.
It's exciting. And then lastly, for someone who maybe is listening to this podcast and is considering getting a spinal cord stimulator themselves, what advice would you give them when they're either looking for someone who's doing it for them or looking for some sort of relief from it?
Yeah, I would say just do your research
Mm-hmm.
and do the due diligence,
Mm-hmm.
because there are a lot of different companies out there. We have to find the one that's right for you.
Mm-hmm.
There are lots of different physicians and places that will do it,
Mm-hmm.
making sure that you feel a good connection and good fit for you on that. I think that having the right technology and the right person doing it makes a big difference. And just making sure that you've really exhausted everything. So some patients say, I've exhausted everything. They come in and maybe,
Yeah.
or do you want to try this?
Right,
And if
right.
they get good relief, then awesome. We've saved them from having a more invasive
Yeah.
procedure.
Yeah.
So some of them come in specifically looking for neuromodulation.
Mm-hmm.
And we find an alternative, actually.
Mm-hmm.
And then maybe eventually go back to it, but want to truly make sure that we've exhausted everything.
Excellent. Well, thank you so much for your time.
Thank you.
As always, I thoroughly enjoyed talking to you, so I appreciate it.
Absolutely.